Okay, I'm addicted to the pit. You're addicted to the pit. Let's watch episode 3. Whoop. I would be critical of the med student in those chest compressions. Like the finger placement is good, the hand placement's good, the depth isn't there. I hope he hasn't been the one pounding the chest for 3 hours, because that's really long. And I'm surprised that they're doing chest compressions and ACLS for 3 hours. I mean, 3 hours of ischemia to the brain is...
Hour 3 this is the 3rd episode. It's the 3rd hour of the show. It's not 3 hours of chest compressions.
Rookie move on my part. Not 3 hours of chest compressions, but these are not good chest compressions. So I assume he's been on the chest for a long period of time, which is actually sort of against the rules. When you run into a code, what the team should do, the code blue team that is, assign roles, and then every 2 minutes, which is considered a round of chest compressions, we should hold chest compressions, look at the rhythm, decide what we're gonna do, and then instantly swap the person performing the chest compressions, because I can't tell you how tired you get performing chest compressions if you're doing them correct. That's 2 inches depression of the chest. Yeah, those aren't good. Ideally, you'd lower the bed and have his body weight on top of the patient.
Oh, shit. What? I think I just broke some ribs.
That's normal. That happens. Remember, the person is technically dead, and you're trying to revive them, resuscitate them. So if that means trading a broken rib for getting good quality circulation because you're actually compressing the chest, good trade-off.
It means you're doing it right.
I will say, looking at his form, he's probably not doing it right. And a weird critique people have in the comments when I call this out on other shows. Dr. Mike, it's an actor. They're gonna harm them. Oh, why would you want them to do it for real? We have humans turning into robots and robots turning into animals, and we can't fake a chest compression on a human body. Let's be real.
Call me if there's a resurrection.
I wouldn't just leave. You can't leave the med student in charge.
Let's see, who's up next at the Deli of Death? Weak and dizzy? No thanks.
Don't make me tell Robbie you're cherry picking.
I'll take projectile vomiting in North 5 for 200, Alex. What do you think the chances are it's a demonic possession?
About the same as you going a whole hour without saying something stupid.
Very great interaction. Reminds me of every time I was in the ER or on the wards.
How are you feeling? Any pain, Minu?
I love this. I can't believe they're including the Seracom interpreter system. I don't know if it's Seracom, that's the brand we use in my hospital. And they're using it the right way. Let me explain this. We have these iPads that are video iPads or whatever, tablets that basically allow us to have an interpreter, I say translator at times, probably interpreter, to help translate the message or interpret the message that we're giving to the patient and have them translate the message that the patient, or interpret the message. God, so complicated. There's a device that helps us understand one another when we speak different languages. But a lot of my med students, what they do is they put the device right next to the patient and they talk to the interpreter. As opposed to what you should do is have the interpreter positioned exactly the way that it is on the show so that you are talking to the patient and the interpreter is speaking behind you, just sharing your message. The idea is to watch what the patient's saying so that you understand and pick up on those very fine cues of the face, of the body, to understand if they're experiencing pain, if there's emotion tied to any of this. Oh, I remember this patient.
How long before we might expect to see some improvement?
It could be hours.
Hours, it could be days.
It could be days, it could be never.
And it's most likely never.
Why don't you guys go get a cup of coffee in the cafeteria, maybe something to eat? I'll have a nurse call you if anything changes while you're out.
And the blood pressure being so low, the chances of any kind of reasonable success here, very, very low.
Third be on board?
3 minutes ago.
How long has he been going at it?
10 minutes in here, possibly 30 minutes of prior downtime.
I mean, 40 minutes without oxygen to the brain, or minimal oxygen because you are doing chest compressions. That's not gonna help anyone.
Do you need a break?
I'm fine.
Yeah, he should not be going 10 minutes. It's every 2 minutes there's a swap off. There's a person actually waiting behind, just like Riblet over here. Rib, I'm trying to review a show.
Hold compressions.
Still no rhythm.
Okay, Whitaker, I think that's enough.
Oh, it's been 4 minutes since the last epi. 1 more minute, please.
Hey, where is she?
My friend
She's in my car. She won't wake up.
Okay. Okay, Mateo, Bernie!
What's her name? Jenna. Come on, Jenna. Wake up for me, baby.
Getting her out of the car is the first most important step. Checking breathing, airway, circulation, all those things. Rib, can I focus on the show? I'm trying to be a makeshift ER doctor.
Pupils pinpoint. I need.
Narcan.
Yeah.
Worried about an opioid overdose, again, as we saw in the previous episode. I didn't see her check a pulse. I think that's very important here. For a non-responsive person, that should be one of the first things that's done. Remember that Narcan is now available at pharmacies across the United States, meaning over the counter. So you can keep some at home on an off chance that you run into someone or someone in your family, or if you're an individual who is perhaps using, know that you should have that available.
I can't find a carotid pulse.
But then we start chest compressions, chest compressions, chest compressions.
5 minutes since the last epi.
Okay, that's it. Hold compressions.
He's my first patient to die.
I'm sorry.
Are you okay?
Yeah.
You sure?
Just, on occasion, I have an emotional response to death.
Emotional responses to death is normal and appropriate. And taking the time to appreciate those responses, react to them, and then move on is totally okay and should be considered normal for a physician. In fact, when patients see a doctor becoming emotional, they don't necessarily view that doctor as weak or worse as a provider. They, in fact, create usually a better doctor-patient alliance.
Does anybody have anything that they wish had gone differently?
In the hall. You should have been on a cardiac monitor. We would have caught the arrest right away.
That's true. But there was no indication for monitoring.
So putting everyone on cardiac monitoring sounds like a good step, but it's A, not always feasible due to a lack of equipment. B, can sometimes create alarm fatigue where alarms are constantly going off in patients who are not acutely sick. And as a result, it distracts doctors, nurses, and everyone else in the vicinity from actually sick patients. So it's not as simple as put everyone on cardiac monitoring. And what they're doing is sort of a unique version of mortality and morbidity rounds, M&M conferences, where when someone loses their life, we keep them in mind for these upcoming M&M conferences where we have a long discussion about the case. We have usually a resident present the entire case. People ask questions, what could have gone better? What could have been improved? And sometimes some of the best lessons come during those M&M conferences, as well as some of the most interesting arguments.
For now, let's harness some good thoughts here for Mr. Milton.
I will say most places are way too busy to have these types of interactions, but wonderful to see.
How are you feeling on this?
I mean, not good. I was just talking to him. Now he's dead.
It's the hardest way to lose a patient. Always hurts.
Especially when it's your fault.
This was not your fault. This was nobody's fault. No doctor on the planet could have caught this. Listen, it sucks, but today was this guy's day to leave this mortal coil. 150,000 people die every day in the world, and you got one of them. But you learn to live with it, you learn to accept it as much as your own mortality and find balance if you can.
You found balance.
No, not even close.
I love the honesty. This is a really good speech.
You're doing great.
This type of mentorship is missing in a lot of ERs these days. Oh, maybe she did have a pulse. The Narcan must have worked.
I'm right here, Jenna.
Came to with one spray of Narcan.
What'd you take, Jenna?
Nothing.
You had to have taken something to cause this.
Okay, no, I was just up late studying and I just couldn't fall asleep.
So you took something to help you sleep? We need to know in order to treat you properly, okay? Do you know what she took?
No.
This could be a sign of something really serious, and we're gonna have to do a lot of tests that you
Okay,
really
I
don't...
took like half a Xanax.
That's not nothing. It's okay.
A, we don't know what the dose of the Xanax that she took half of is. B, you don't want to be judgmental like that because then the patient's not going to be forthcoming with you. And there's no reason to be judgmental. Your purpose there is to help the patient to make sure that they're stabilized and then treated, not to be able to put your baggage on them or to make editorialized statements about it.
You taken Xanax before?
First time.
Okay.
Xanax, generic name of the medication alprazolam, is in a class of medication called benzodiazepines. The benzodiazepine is an anxiolytic. It's meant to break anxiety. Usually, they're supposed to be used for breakthrough anxiety attacks with someone who has generalized anxiety disorder or for panic attacks. However, there are individuals who are perhaps overusing the medication, who are using it as a controller medication, and it's very difficult to get those patients off of it because they are habit forming. For those who take it to fall asleep every night, it's very difficult to fall asleep once you've been on it long term. But we've seen the data that those who take those medications long term, especially for sleep, especially if they're elderly, have worse outcomes when it comes to neurocognitive status. So we try and get patients off of them. But it's not easy to get a patient off of them because again, they're habit forming and you have to taper them very carefully. Otherwise, you could put someone into withdrawal, which is very, very serious, especially for benzodiazepines.
The radiodensity right below.
Is it pneumonia?
Possibly. Or it just changes from vaso-occlusion of the sickle cells.
It's called acute chest syndrome. We're gonna cover you with antibiotics just to be on the safe side.
No, we've been through this before.
Third generation cephalosporin and a macrolide.
Perfect.
The reason why we choose certain antibiotics for specific conditions is based on the bacteria we suspect to be present causing said infection. Every hospital will have a specific list of medications that they believe work for a specific condition based on local bacteria presence. So there are certain communities where there is actually resistance to certain antibiotics, and we have to be aware of that. So we actually have in our hospital intranet where we can look up which antibiotics should be used, which antibiotics carry a high rate of resistance in the local area.
Okay. You're gonna recover. Okay?
Good luck.
But wait, what happens now? We monitor her heart and breathing for the next few hours to make sure she doesn't need more Narcan.
That's it?
Yeah. You should text your friends. You should text your whole college. Tell anyone to listen to not take pills without a real prescription unless they want to end up here.
So what they're saying is the Xanax that she took was illegally sold and potentially laced with maybe fentanyl or some kind of opioid. And as a result, it caused her to have her breathing slowed to a very dangerous point to where she lost consciousness.
This is Hank?
What happened?
Oh, nothing. We were just Raymond and my buddy Joey.
Oh, I see a nail in the chest, and it's like right where the heart is. Oh, man.
And then he points his fucking nail gun at my head. So what would you do? So I freaked out. And then in the ensuing melee, he shoots me.
Melee?
Yeah, you know, like a scuffle, like a Donnybrook. What, you think because I work construction, not a hospital, I don't have a fucking vocabulary? Tier 1 trauma now?
No, sir.
Whoa, definitely intracardiac.
I gotta tell you, this hurts.
The fact that he's still talking is really impressive because if that pierced the myocardium, like the tissue of the heart, it must be causing a tamponade effect. Not the tamponade that they always talk about from fluid building up in the pericardial sac, but more so a tamponade effect of the nail is putting pressure, preventing blood loss from within the heart. And if you pull it out, that tamponade effect is gone, massive bleeding, death.
Hank, you take medicine every day? Any allergies to medication?
No, can you give me something for the pain already? Is this a hospital or a vet clinic?
Very soon, Hank, very soon.
You say that to the beagles too.
Pulse 120 BP, 100 over 65.
How is he not bleeding out? I'm so like in shock about this.
Whoa, that looks intracardiac.
Oh, nailed it.
Oh, you got jokes now.
No jokes, just pushing your pain meds, buddy.
Small pericardial effusion.
Yeah, I'm surprised they're not just instantly taking him to crack his chest and perform intrathoracic surgery. As soon as that nail comes out, massive bleeding ensues. Very quick death if you're not acting.
It's not cardiac case.
I guess I'm just a little bit ahead of the show.
There is blood collecting in the sac around your heart. You need surgery before your heart stops from the pressure around it.
And from bleeding out once you pull the nail out.
Just pull the nail out.
That would definitely kill you.
Or I can take him in 10 minutes.
Mind if we intubate him first?
Sooner the better for all of us.
Great. 120 of sucks, 100 of ketamine.
They are sedating him.
Good view of the glottis.
They're doing an intubation here to make sure that they're able to protect the airway and aerate the lungs.
And insert the tube around the bend.
You stole my med student from triage? How's she doing over here?
Doing pretty good.
I never had this level of tech when I intubated patients. I had just a basic tool, I forgot even the name of it. And what was interesting is if you put too much pressure on it, it would literally make a cracking sound so you don't break the patient's jaw, which a lot of people back in the day used to do. Maybe not the jaw, but more so the teeth. If you don't angle it correctly, it's very possible to do that.
Pressure's down, 72-38.
Effusion has grown.
He's bleeding.
Now with RV collapse.
That means the right ventricle has collapsed. That's one of the 4 chambers of the heart.
Pericardiocentesis.
Let's get another unit on that infuser. Prep for thoracotomy. Coming through.
They're literally gonna crack his chest right there in the ER because he's bleeding out, and if they don't stop the bleed, he dies.
That's
Dr. Santos, how do we cut through the intercostals?
through the superior rib to avoid the neurovascular bundle.
That is correct.
Finish that retractor.
Full suction. And get rid of this nail before I get poked.
On it.
I'm surprised they're doing that before they're ready to start suturing.
Nails intact. In one piece.
That is a way to end up with a really severe infection. So you want to verify the patient's tetanus vaccine status, and if he was never vaccinated or it's unknown, or if it was past 5 years, there's a specific set of protocol.
Opening the pericardium.
First unit is in, pressure's up.
Heart is filling well. Throwing her horizontal mattress and we're out of here.
Stop the bleed while I sew. STEMI's arrived.
You got this?
Just wrapping him up for OR delivery.
Code STEMI means someone's coming in with a myocardial infarction. STEMI really stands for ST elevation myocardial infarction, kind of a mouthful, but it really just decides for us that they're seeing on an EKG a specific rhythm that is signaling that there is not enough oxygen being delivered to some part of the heart. Now, based on where that ST elevation pattern that we're seeing on the EKG, we can decipher, or at least point us in the right direction of which artery potentially is blocked and which part of the heart is struggling. But whenever you have a patient coming in with a STEMI, you think about door to balloon time, which is how quickly you can get into the PCI suite where they're actually doing a catheterization. And hospitals are judged on this door to balloon time very strictly, because if it takes you too long, enough of the heart muscle dies, the patient may not recover.
Kiara? Hi, I'm Dr. Melissa King. Everyone calls me Mel.
Yes, we met.
Right.
I would still take the hand. I think it's bad juju. It's not a medical term, but I think it would make the person feel comfortable. And remind them that we met. Maybe they forgot, maybe they were stressed, maybe they thought I was someone else.
Stimmy with me, Mel.
Right behind you.
Dana, what's open?
Trauma 2.
All right, keep it that way.
Mr. Ed Gellin is 52 years young with a history of hypertension and hyperlipidemia, 20 minutes of substernal chest pain.
He has high blood pressure, high cholesterol, and is having some chest pain.
10 out of 10 with dyspnea and diaphoresis.
Sweating and shortness of breath.
BP is 152 over 95.
So he's hypertensive still.
Currently chewing 324 mgs of baby aspirin.
Okay.
Blood's drawn, second IV started, BT stable.
So you could see right away where those ST elevations are.
7 millimeters
nitro
of
spray
ST elevation in the
sublingual.
anterior lead.
These are sometimes called tombstones.
Open up, sir.
Tombstone?
Lift the tongue.
Mr. Gellin, you're having a very big heart attack right now. The major artery that carries oxygen to your heart is almost totally blocked.
Also known as the LAD.
We're going to send you up to the cath lab. A cardiologist is going to unblock that with a balloon and leave it open with a stent.
And afterwards, you're discharged on a very specific set of medications, some antiplatelet medications, cholesterol protective medications, and there have been major studies that have been done to change the cocktail of medications that you are discharged with after you suffered a heart attack. And that management has changed over the years depending on which trial you are following, and usually the most up-to-date trial, which is a bit out of my scope because I have not treated acutely an NSTEMI probably in 6 or 7 years.
She has her entire medical history on her phone. It's extremely long.
Dr. Mohan, do you have a minute?
Yep. Excuse me.
Is there a problem over there?
No, her pain's well controlled.
You understand that's my polite way of asking why you're spending so much time with one patient? You're an R3. As an R3, you should be seeing at least 2 patients an hour.
I have to. Joyce and Mr. Wallace are good Samaritans.
Who's comatose and stable, you should have 4 by now.
I have the highest patient satisfaction of anyone.
I don't doubt it, but we just had this conversation a couple hours
I know
ago.
people call me slow-mo.
Because you're afraid of making a mistake?
I'm always afraid of making a mistake, aren't you?
Yeah, of course I am, but you know what I mean. You make a mistake once and somebody dies and you feel so badly about it, you'll never let it happen.
How is that wrong?
Because you waste time and money on unnecessary tests. You keep sick patients waiting too long. You miss out on cases you could be learning from. You shortchange your own education. I'm not saying this to be a hard ass. I'm saying this because I know you can do this, but you need to do it at a level I also know you're capable of.
That's a really good combination of positive and negative criticism. If you just approach it with negativity, it's not going to motivate a student or a resident to learn. But in a situation like this, if you do work so slow, other patients will be harmed by your slowness, even though you're trying to deliver the best quality care. Ideally, in a situation like this, you work hand in hand with a superior to see where you could speed things up, have someone evaluate, write reviews about yourself, about what you could have done better in a case. And then with time, you could slowly start seeing improvements.
And what if I'm not?
Then you should look into a specialty that better suits you. Have you thought about psychiatry?
I don't want to go into psychiatry. I want to be here.
Being here means no matter how good you are or how hard you try, you're going to make another mistake. And someone else might even die. That's called being an emergency medicine doctor. If you can't accept that, then maybe this isn't the place for you.
I can accept that.
I think it's a little bit early to start saying if she can't accept it, find a different specialty. I think maybe we could let her develop a little bit more.
Is it good or bad?
If there's no spontaneous breathing, then carbon dioxide levels rise above 60, so 82. Definitely means that Nick's brainstem is not triggering him to breathe.
Well, how can you fix that?
We can't. I'm sorry.
Isn't there anything else?
We can do an imaging test called the cerebral perfusion study.
Then let's do it.
But you have to understand that would be the last test, what we would do. If it comes back that there's no blood flow to Nick's brain, it would confirm beyond a shadow of a doubt that there's been brain death, which would mean that he's gone.
That's heavy, and obviously every doctor is going to handle it differently. I think the more you can prepare a patient or their family for the bad news, but then be transparent and honest about it, usually the better the outcomes and the more grateful people are.
Could I get some Mylanta for Mr. Fulton in Central 14?
It'll be a while. If you want it fast, go check out the employee first aid cabinet.
Why would it take a while to get Mylanta?
How's it going?
Not so great. I lost a patient.
So I heard. Also heard it wasn't your fault.
Doesn't make it feel any better.
If it's any consolation, I just got scolded for going too slow. If you're someone talking about a slow-mo, that's me.
Guaranteed you're going faster than me.
I like to say it gets easier. Some days it does. I'm sure the rest of your shift will be better. Shake it first. Oh, but make sure the lid is...
Rookie mistake. Usually we have like these scrub dispensing machines at hospitals where you like swipe your ID card and they dispense you a pair of scrubs that you could wear and then return at the end of your shift.
Why is he so agitated?
He could have some awareness of the tube in his throat, or that he's in a strange place, or it could be lack of oxygen to his brain.
Does he need more oxygen?
He's on 100%. That's as high as it goes. That is his blood pressure dropping.
Oh. Is that even fixable?
Normally, yes, with IV fluids, but we now know that that will just fill up his lungs, drop his oxygen even more.
I hope they don't ask for pressors here.
Wasn't there something else we can do?
We can place a long, large IV catheter in his jugular vein down into his heart.
So he's talking about a central line, and through the central line, you can give pressors like adrenaline. Now, it usually isn't epinephrine. It's usually a type of adrenaline. There's different types depending on what's causing the patient shock that have better outcomes. But in a situation like this, obviously, you wouldn't want that because his heart's already in a bad place. He's just decompensating. And as a result, doing more really is just creating more negative outcomes.
And administer Levophed, which is a very powerful medicine, constrict his arteries, raise his blood pressure. But that could cause other organ damage, organ failure. I'm really sorry, but each new step is even more invasive, could cause more suffering with minimal benefit.
I would say minimal to none.
Hi. Dr. Robbie said he'd be back in a few minutes.
Yeah, he's with the patient, but I'll let him know.
My son is dead, isn't he?
I'm not a doctor, Mr. Bradley, but I do believe in God, and I am praying for your boy with every beat of my heart.
But it was actually bent.
Thank you.
Yeah. Oh, 1 second.
Yeah. She was legitimately dead? Yeah, like 100%.
Mr. Bradley?
Vince?
Oh, is there a connection because he's the one supplying people with Xanax that is laced with fentanyl?
I just needed to sleep. I thought I was.
Where did you get the drugs?
Whoa, security.
Did you give my son drugs?
Mr. Bradley, you can't come in here. Mr. Bradley, please, let me
is
help
this?
you
Tell
out
me
of
the
here.
f***ing truth.
Security!
Nick's dad. Did you drug
Where the hell's
my
security?
son?
Your son gave me the drugs. Toll, ask him.
He's dead. And you are a f***ing liar. You killed my son!
This is where I worry not just for the patients, but also for the medical providers. Nurses get assaulted at some of the highest rates, and a lot of times it goes underreported, even though the stats are already sky high. And the issue is, unlike, let's say, a bus driver here in New York, an MTA bus driver, they're protected by federal law where there is a minimum sentence when you assault a bus driver. But for some reason, nurses, doctors, we don't have that protection, and I never understood why. Oh, look, he's at the scrub machine. Yeah, usually they give you 2 credits, so you don't take more than 2 at a time.
Hey, there's no scrubs in here.
Yeah, you have to put your old ones in before it'll give you a new pair.
What?
Is he gonna put on a patient gown? We also have, it's like a uniform department or an equipment department where you can go and they do have scrubs that they can hand you if the machine has some error with it. So he could technically go there, put on new scrubs, take those off, and then return those. See, I would ask if this is cool before doing it.
Forgive me, Mr. Milton.
Oh, that's awkward. Don't do that. Bathroom, guy. Bathroom.
Come on, baby.
1 credit. Their hospital gives out nice scrubs.
Hey, been looking all over for you. We need a cardiovert unstable AFib in North 1.
Okay, just give me a sec.
Systolic's 90.
Me.
Someone who has atrial fibrillation basically means their heart is usually beating rapidly, but more so in a very specific abnormal rhythm, what we call irregularly irregular rhythm. What ends up happening is it puts stress on the heart, but it could also raise the risk of developing a clot inside the heart that can then get shot out to the brain, leading to a stroke.
35-year-old architects working on a deadline, vaping nicotine all night, palpitations this morning, AFib at 147. Mr. Quinn, this is Dr. Robbie.
Hello, sir. How you feeling? Like crap? When did your palpitations start?
You could see on the rhythm monitor behind how abnormal it is.
You understand we need to shock your heart back to normal? It's gonna hurt.
You'll be sedated.
I'm surprised they do that right away. In places where I've worked, we usually give medications in a situation like this in order to try and get a patient into a normal rhythm.
Mel, 75 of propofol, slow IV push.
How much did you vape last night?
A couple of pods.
Vape every day?
I do, but not that much.
How much nicotine is in a pod? Anybody know?
No idea.
40 milligrams, same as a pack of cigarettes.
Wow, 2 packs in one night.
Mel, what's the safe window for cardioversion?
12 hours.
What happens after that?
Increased risk of embolic stroke from left atrial blood clot.
Which he does not have.
Charged.
Clear. Bingo.
So remember, when you're cardioverting a patient, you're trying to put them, restarting the rhythm and put it back into the normal, what we call sinus rhythm.
Sinus rhythm. Cycle BP.
We'll monitor for a few hours.
Yeah, let's get addiction services on the case, too. He's gonna need a daily patch of nicotine gum for breakthrough cravings. This one's a bitch to kick.
Nicotine addiction is really problematic. And when we have patients that are admitted to the hospital and they can't smoke, we generally put them on a patch while they're admitted, dosing it based on the amount of packs per day that they smoke.
Where do you think you're going, Myrna?
Oh, none of your business, fruitcake.
Actually, everything that happens in this department is my business. And you know what? I put up with a lot around here. I take very good care of you, so you can call me Dr. Rabinovich. Call me Dr. Robbie, or you can use my first name of Michael.
His name is Dr. Mike?
Who knew?
Wow.
Oh, did I hurt your feelings, sucker?
That said, it has a certain whimsical quality to it that I could probably learn to live with.
Whatever you say, fruitcake.
Excuse me, doctor. My father's starting to struggle again.
Okay.
What can you do to make him more comfortable?
We can take the tube out.
But he needs that to breathe.
If we extubate, we would keep him on oxygen for comfort. It would decrease his sedation. He might regain consciousness. He could recognize you, maybe even speak.
Well, I don't want to do anything to jeopardize him getting better.
That's just the point, Helen. He's never getting better.
That realization is very important to reach.
You don't know that.
I do know that, okay? He knows that. And Dad probably even knows it. It's time to let him go.
I'm sorry if you've had your fill of Dad, but I haven't. And I am not giving up on him.
Even if it's hurting him? I'm sorry, but if there was anything I could do to heal your father, I would do it. But the most humane thing that I can do for him is to allow him a painless, peaceful passing.
How long will it take once the tube's out?
I never make this statement because I've been shocked at lengths that people survive post-extubation.
From minutes to hours, but we would ensure that he'd be in no physical discomfort.
I've even been in a situation where I needed to call the time of death before the organ transplant team was there to get the organs. And as I'm standing over the patient and the patient's been extubated, all the stuff already for a good amount of time, we thought the patient would die instantly. They didn't, and there's nothing you can do. So the organ transplant team is standing there scrubbed in, just waiting for little old me to call time of death. And I'm not gonna do it prematurely, so I had to wait an awkward amount of time until the person officially passed, and then we were able to get the organs.
Okay.
Wow. Did you know that the polio vaccine is partially responsible for the loss of trust in vaccines? Click here to check out the story. Very interesting, worth the watch, and as always, stay happy and healthy.